Okay, I think we're ready to begin the celebration today. For those of you who don't know me, my name is Ed Hawrot. I serve as the program coordinator on Advance CTR, and it's my pleasure today to welcome you to join us in this special celebration of our program's 10th year milestone. Tonight we honor the decade of discovery, the collaborative spirit, and the tangible impact of Advance RI-CTR, which, as you know, is a statewide hub for clinical and translational research that has supported Rhode Island investigators through pilot funding, research services, and the consultations, professional development, and expanded our connections across the institutions. I like that previous slide, though. It's terrific with all the photos of our folks. So I left it on a little bit longer. But this is the decade of discovery. We're not humble. So I'm going to first of all give you a quick overview of our program schedule, which will run through to about 5:30 with our keynote speaker, Dr. William Powderly. And then there will be a reception afterwards in the atrium till 7 o'clock. So please try. Hopefully you'll attend and you'll text your friends to come and join us. So on the next slide, we dug this out of the archives. This is from the summer of 2017. So this is year one of our award, which had started the previous August. And so we have the leadership here, a dozen or so of the core coordinators, so-called core coordinators, and then 4 project managers. A special call out to Helen Leffers, who's on the right-hand side just above Sharon, was the director of our admin core. And then in the front row, Heather Fournier, who is attending here, who has now moved on to the administration in the medical school. I'd like to especially point out in the lower right and left-hand lower corner, Jim Padbury and Sharon Rounds. Yeah, you'll be hearing more from Sharon before the rest of the program. And Jim Padbury was our initial PI, program director. And although this photo was taken in 2017, it was years of work to actually get to this point. And Jim was our leader through the first award and also through the renewal award. Now, I had the privilege to be part of this team, and that began over 10 years ago. We submitted our NIH application in October of 2014. That application was preceded by years of prep work. And we requested a start date of July 2015, but funding wasn't issued until June of the following year. And so our grant award notice came in for August 1, 2016. I quickly looked back on some of the history there, and what had been happening was, this is under Obama, and there was the previous year there had been a budget issue. And it had been 12 years or so where the NIH budget was basically flatlined. But that year in December, so almost exactly 10 years ago, the Republicans and the Democrats in a bipartisan manner voted to increase the NIH budget by $2 billion, from $30 to $32 billion. And that really broke the dam for a lot of NIH funding. And we here at Brown were recipients of that. So again, our award started August 1 of 2016, and we're currently in our 10th year. Over the past 10 years, Advance CTR has helped to launch scientific careers, strengthen research capacity, build community partnerships, and move scientific insights into real-world health solutions for our state. As we mark this decade of discovery, I invite you to reflect on 3 important components contributing to this celebration today. First of all, the people, the investigators, research staff, community partners, and mentors whose energy, creativity, and commitment drive the work. Secondly, our partners. Across the partnership across Brown, the University of Rhode Island, CARE New England, Brown University Health, and the VA Providence healthcare system. This collective network has grown to be much stronger than the sum of its individual parts. Finally, the third component, the impact, not just in our labs and clinics, but in our communities. Improving health, advancing equity, and elevating Rhode Island's role in nationally recognized translational research. Before we proceed further into the program, we'd like to share with you a short video that our admin core staff prepared for this event that captures many of these elements, the stories, the milestones, the future vision. So here we'll kick off that video.
A decade of collective innovation.
A decade of discovery. It's also been a decade of teamwork.
A decade of Advance RI-CTR has been an amazing way to move discovery into translation efforts, into real world practice.
A decade of acceleration. And we're really accelerating research in Rhode Island.
Decade of real multidisciplinary research. If we take a look at the portfolio that Advance CTR, RI-CTR has done, we see projects founded from basic science to more clinical, like hands-on implications.
I think it, in many ways, still retains the original intention of the of this mechanism of funding, clinical and translational research, and that's research, the building of research capacity.
Professionally transformational, especially for early career researchers.
If I could describe the program in one word, I would describe Advance RI-CTR as collaborative. It's been really extraordinary to work across different cores that have different emphases, different expertise, different skills.
If I could describe Advanced CTR in just a phrase, I would say transforming potential into impact.
I guess I would say advance is what it means to me. But advancing in a number of different areas.
What's really stood out for me about RI-CTR during this time that I've been involved is how I can also bring in different early career investigators into the program throughout the time, not just from a consultation and providing services perspective, but also people who can be involved as co-investigators and collaborators.
Looking back over 10 years ago when we first started hammering out the outlines of our proposal, it was a real team building exercise.
It's been teamwork that has brought together people from all of our institutional partners to work together toward one goal. And so this teamwork has been really quite remarkable, and I think is the secret sauce of the success of Advanced Rhode Island CTR.
What stands out to me is that there are so many people in this scientific community who are eager to learn and also willing to share their expertise to grow this ecosystem of clinical and translational research. So Advanced CTR provides programs and resources that are a catalyst for new discoveries, but the energy source is the shared curiosity, commitment, and collaboration. Part of the very first class of CTR mentored research awardees, and it came for me at this really fork in the road for my research. So I had just finished postdoc, and this award came right at that fork in the road. I was about to take a non-research role, 100% non-research role, and this award gave me the opportunity to give me 75% protected research time. It gave me a little nugget of research awards, and I think
really why today I'm still in the research path.
For me, this has been a remarkable learning experience. I've learned so much from my colleagues and from the investigators and the faculty with whom we've interacted.
I'm grateful for everyone who supported this NIH funding mechanism itself, and the faculty who have done the heavy lifting in securing and maintaining 10 years of funding. And cheers to 5 more years of funding.
You can have grand strategic plans, but you need a positive, strong culture, and I think we have that. And I think that's the other thing. We have that in Advance CTR, and I think that has grown out of CTR across the state. And having that positive, very positive culture, shared values, feeling part of the team helps accelerate any change.
I think I'm just very grateful for the support. Personally, it really has been transformational for my career, and so that to keep up this good work, it advances the science and keeps scientists in Rhode Island. That's what it's done for me, and so I hope that there'll be another 10 years.
One thing I'd love to say to the team is thank you to the community of Rhode Island. It's a small but mighty state. Thank you for your efforts in partnering with us. And thank you also to Sharon, Ed, and Method for your tremendous leadership and growth and creativity in the process of how to really bring discovery into real world practice.
Well, I'd like to say thank you to everyone, staff, faculty, researchers, the leadership of our institutional partners who have been so generous and supportive of everything that we've done. I think, a huge thank you is owed to all of them, all of you, and we look forward to another great 10 years.
Isn't that fantastic? That's great. At this point in the celebration, it's my pleasure to introduce a special guest who joins us virtually this evening, Congressman Gabe Amo. Congressman Amo represents Rhode Island's 1st Congressional District and is a proud advocate for scientific innovation, public health, and equitable access through research resources. Throughout his career, from serving in the White House Office of Intergovernmental Affairs to representing our state in Congress, he has been a strong voice for investing in the people and institutions that advance discovery and improve lives. We are deeply grateful for his support of research initiatives such as Advance RI-CTR, which embody the collaboration and innovation that define Rhode Island's scientific community. We will now hear from Congressman Gabe Amo, who has shared his remarks with us virtually in recognition of Advance RI-CTR's 10-year anniversary.
Hi everyone, Congressman Gabe Amo here. Although I'm unable to celebrate with you in person, I'm proud to join you in marking a decade of discovery, collaboration, and impact through the Advanced Rhode Island Clinical and Translational Research Program. 10 years ago, Advance RI-CTR was launched with a bold mission to invest in infrastructure and researchers needed to tackle Rhode Island's most pressing health challenges and to foster collaboration to achieve those goals. The program has supported biomedical and public health scholars across Rhode Island who are turning scientific discoveries into real-world solutions that improve patients' lives. Its focus on translational research, moving discoveries from the laboratory bench to the clinic, to practice, and ultimately to patients and communities is exactly what makes this initiative so impactful. The program has become a statewide hub for innovation, bringing together strong research partners from the University of Rhode Island, Brown University Health Care New England, and the VA Providence healthcare system. Together, these institutions have built a powerful ecosystem, one that supports early career investigators and drives research that improves our state's health. As a proud Rhode Islander and your congressman, I believe deeply in the importance of federal investment in research and innovation. When we fund programs like Advance RI-CTR, we are not just advancing science, but strengthening our communities. We're also creating jobs. We're training the next generation of health leaders. We're ensuring that breakthroughs in the lab translate into better outcomes for patients and families alike. Whether it's tackling chronic disease, improving mental health care, or addressing disparities in healthcare, the work being done here in Rhode Island is vital to building a healthier, more equitable healthcare system. But let's be very clear, this progress is only possible when we protect and prioritize research funding. Trump's efforts to cut NIH funding and the ongoing Republican government shutdown put at risk the very agency whose work made this program possible. But I stand ready to defend these federal research investments because it is important to our country and Rhode Island. Earlier this year, I led over 150 members in opposing Trump's NIH cuts, and I'm working on legislation right now to protect research institutions from sudden changes to funding rules in the future. So as we mark this 10-year milestone, let's continue to invest in research that reflects the needs of our communities and support the scientists who are driving that change. Congratulations on this massive achievement. I am so very proud of how far we've come and even more excited about the next decade of discovery in the Ocean State. Thank you for everything you've done.
Thanks again to Congressman Amo for these remarks and continued advocacy for clinical and translational research in Rhode Island. It's now my distinct pleasure to introduce Dr. Mukesh Jain, Senior Vice President for Health Affairs and Dean of Medicine and Biological Sciences at Brown University. Since stepping into this role in March of 2022, Dean Jain has brought to the state of Rhode Island his global stature as a physician and scientist, builder of research infrastructure, and a champion of translational discovery. His leadership continues to be instrumental in fulfilling the mission of Advance RI-CTR, strengthening Rhode Island's capacity for clinical and translational research, training the next generation of investigators and physician scientists, and ensuring our discoveries translate into positive health impact for our community. Please join me in welcoming Dean Mukesh Jain.
All right, I have to adjust this, I'm a little shorter. All right, good afternoon, everyone, and thanks, Ed, for that very kind introduction. So I want to just start and express my gratitude to Ed, to Sharon, as our leaders and directors of the program. They've really been absolutely instrumental, as you heard from Ed's history, particularly over the last 10 years, to make sure that the program has been as successful as it has. So their dedication, creativity, tireless work. I think people that have done large grants like this know what it takes to keep it going over an extended period of time. And that effort has really made this program what it is today, a model of innovation, collaboration, and impact. From the beginning in 2016, Advance CTR has been a model, as you heard from Gabe Amo and from Ed, statewide multi-institutional partnership, bringing together Brown, URI, our health system partners in the VA, Care New England, and Brown Health, and community organizations to accelerate discovery and impact human health. The collaborations that we've seen over these past 10 years prove that when institutions work together, you can create something that no one could achieve alone. The sum of the parts is much stronger than the individual. So just a few reference points over the past decade. These reference points, this first one is really important, and Dr. Rounds really wants it emphasized. All right? So over the past decade, Advanced CTR has demonstrated extraordinary returns on investment. For every dollar invested in network investigators through pilot projects, mentored awards, big data awards, grant resubmission, innovation awards, there has been a $12 return in extramural funding across our partners. So that is more than $132 million in external funding over the past 10 years. I think that deserves a round of applause. I have to stay in Sharon's good graces. We're good, right? I did that right. Okay, all right. But in all seriousness, they reflect more than just financial returns. They represent momentum, collaboration, and a growing ecosystem of discovery across our state that's building careers and communities. So with respect to careers, it's programs like Advance K and Advanced R that have built a pipeline of investigators focused on tackling real health challenges, from chronic disease prevention to mental health and aging. 43 Advanced K scholars who've collectively brought in $13 million external funding, and importantly, 2/3 have submitted K or Career Development Awards. 15 Advanced R participants who've then competed for R-level research, driving studies that address unmet challenges in the community. 300 mentors trained, and our community engaged studios have connected researchers and community partners in 9 interactive sessions, ensuring that science we pursue is informed by the needs and the voices of the people that it aims to help, that it aims to serve. And there's a lot of acronyms here, don't test me, through BIRD, BIPSI, and CEO cores, more than 2,000 consultations have been provided for our investigators in turning their questions into actionable, impactful research. So together, all of us as a community have strengthened Rhode Island's research infrastructure, elevated mentoring culture, and deepened the connection between scientific innovation and better health outcomes. And beyond some of these numbers, Advance CTR has really helped turn research into results, improving health and quality of life across Rhode Island. As we look ahead, our goal is clear: to strengthen these partnerships even further, expand opportunities across Rhode Island, and continue advancing clinical and translational research that makes a real difference in people's lives. And I can tell you from the perspective of leaders, be it at the medical school, the university, Dr. Wagner, who is in the back as leader of Care New England, Mr. Fernandez at Brown University Health, and President Parlange, there is a deep commitment to that. The next decade will demand even greater collaboration and commitment from our institutions, our investigators, our community partners, to build on the success and sustain Rhode Island's efforts in translational science. So 10 years of Advance RI-CTR is a milestone certainly worth celebrating, and a powerful reminder of what's possible when we collaborate, when we have a shared vision, and we work together. And I'm really grateful, as Ed said, really grateful to every faculty member, every mentor, community partner who's been part of this journey. So with that, it's my pleasure to introduce someone whose leadership has been central to this journey, and someone that I will always want to stay on the good side of, Dr. Sharon Rounds. Sharon, as you heard, co-led the pilot project core, and then in phase 2, assumed the role of program director and PI of Advance CTR. Please join me in welcoming Dr. Sharon Rounds.
Thank you. So, thanks everybody for being here with us today. This is a really exciting milestone for all of us who've been involved with Advanced CTR for the last 10 years. This collaboration of Brown, the University of Rhode Island, and our hospital partners, and thank you all for being with us today, has been a really exciting experience developing a statewide network. Let's see. So Advanced CTR is part of a national institutional development award funding system that's funded through the National Institute of General Medical Sciences of the NIH. And it's designed to increase research capacity in states that are underrepresented historically in NIH funding. Now, Rhode Island is as has been mentioned, a small but mighty member of the IDEA network. And I have to say that our statewide IDEA funding is, I believe now, #1 in the country. So what we lack in area, we make up for in our ambition and our wonderful investigators who've done such a great job. Now, through this IDEA support, the original leadership of Advance Rhode Island CTR, Jim Padbury, Ed Hawrot, Helen Leffers, built an infrastructure of Rhode Island institutions and a robust research ecosystem. We're proud of this infrastructure, but what really defines Advance Rhode Island CTR is its people. The investigators, the mentors, the research coordinators, and the community partners, and certainly our support staff who've made discovery such a wonderful team effort. Now, this is a snapshot of the past 2 phases and the opportunities that the IDEA program has provided the state. Last month, we submitted our renewal application for phase 3, and if funded, we'll begin the next phase of funding in August of 2026, with increased opportunities and awards, which I'll mention in more depth in a moment. Over the past decade, the advanced CTRs consisted of integrated cores. We've provided expert consultations and trainings through the BIRD, bioinformatics, and professional community engagement and outreach cores. The Professional Development Corps has trained the next generation through mentoring workshops, writing courses, and seminar series. The Pilot Projects Corps has seeded innovative ideas that have gone on to secure major extramural funding. And the Administrative Corps and Tracking and Evaluation Corps have been the engines that have kept the trains running and also provided us with solid data on the outcomes of all these activities. I'd like to share a brief overview of some of our impacts to date. This is just a quick snapshot. Take a look at the posters out in the atrium, which and also the brochure that it was available for everyone, which gives a little bit more detail on the return on investment that all of these activities have had. Now, we have awarded substantial new funding to investigators across our partner institutions. These have supported projects spanning the really vast range of research from infectious disease to behavioral science. This slide shows how this funding has been distributed across our partner institutions since 2016 and includes pilot awards, mentored research awards, grant resubmission awards, innovation awards, and big data awards. So a whole host of seed funding opportunities. 2 of our most impactful programs have been the Advance K and the Advance R programs. Advance K started in the fall of 2019 and assists with the preparation of K-type career development awards in a rigorous year-long program with a standardized curriculum, but also customized activities and consultations to meet the needs of our individuals who have quite different learning goals. Advance R, which is more recent, beginning in fall of 2022, helps investigators prepare R-type research awards, providing internal study sections with NIH-style feedback, as well as grantsmanship coaching, and coaching on issues related to the submission process, which can be quite daunting for early-stage investigators. This slide highlights participation in the Advance K and Advance R programs by faculty in our various partner institutions. And these programs have strengthened the pipeline of career development awardees throughout the state. As Mukesh mentioned, the Advanced K scholars have gone on, 2/3 of them, to apply for career development awards, and of those, 40% have been funded, and we're very proud of that achievement. The Advanced CTR Research Mentor Training Program, which was one of Ira Wilson's many contributions to Advanced CTR at the very beginning, is a day-long peer-driven program that provides faculty research mentors with skills and techniques to enhance communication with their mentees, to improve their outcomes in professional development as well as research success. It's based on the nationally recognized evidence-based curriculum developed at the University of Wisconsin from the National Research Mentoring Network and the Center for Improvement of Mentored Experiences in Research. And as you can see from this slide, there's been really remarkable engagement of faculty from all of our institutions and over 20 departments, and with great feedback in terms of what they gained from the programs. This slide provides a really brief snapshot of the diverse workshops, seminars, webinars, professional development opportunities, courses, etc., offered over the past decade, a really incredible array of activities. Now, throughout the course of Advanced CTR, we've had the opportunity to apply for supplemental awards to the parent program. And Advanced Rhode Island CTR affiliated faculty have really risen to the occasion and have been remarkably successful in obtaining these supplemental awards across our partner institutions. These supplements have been very valuable because they provide seed funding to support new projects, new ideas, and new collaborations. So, what will the future hold? So as we're looking ahead to phase 3, we're building on a strong foundation, but we have challenges. And we're looking forward to those. The next phase will expand core services, deepen collaborations, and focus upon improving our current network to include more local, community, and national partners. A major focus of phase 3 is for Advanced Rhode Island CTR to become a networked CTR. The future phase 3 structure will be slightly different in that a couple of cores have been merged. The administrative core and the tracking and evaluation core are now one. The pilot project core has become the health research core, and you'll see why in a moment. And the biostats and informatics cores have been merged to become the, the research, design, compliance, and data management core. I always have to think about that, which is a mouthful. So this new structure will help us strengthen both our service offerings, our consultations, and we believe will improve the investigator experience overall. And of course, we will continue to benefit from input from our institutional partners through our executive and steering committees, and also from external advisors through our external advisory committee. Now, the administrative core will be bringing on additional staff to support investigators and also navigation of investigators through what can seem like a maze of offerings and services. In addition, we are developing a new data management system that will create profiles for investigators so that they can more easily access services, trainings, and awards, and also have access to a record of their engagement with Advance CTR. We're going to continue rigorous program evaluation using the nationally recognized and validated translational science benefits model. And we consider this to be an extremely important aspect of Phase 3. In the professional development core, we're very pleased to be able to increase our opportunities by sponsoring seats, as it were, shall I say, scholarships for the Qualitative Science and Methods Training Program, and also the Bridge Implementation Science Boot Camp. We're going to be developing an intensive multi-week clinical trials training program designed to help with investigators who wish to begin investigator-initiated research studies. And I can tell you from personal experience that this training is sorely needed. I'm looking forward to taking it, actually. We will be offering consultations and trainings in digital health through our collaboration with the Brown Digital Health Center. The iScore program, which is currently active, will be expanded to provide additional training for clinical research coordinators, who are really the engines that are driving and the critical components of any human studies research. And then finally, in response to perceived underappreciation, shall we say, of science by the general public, we're planning to offer training in science communication, which I think is sorely needed. The Research Design Compliance and Data Management Core will be offering new training and opportunities focused on artificial intelligence. We'll be supporting research using so-called real-world data, including real-world data originating from our clinical practices here in Rhode Island. There will be consultations and trainings on regulatory research issues offered in collaboration with the folks from the Regulatory Advisory Unit from the Brown Division of Research, and new trainings in quantitative and qualitative analysis and implementation science. The Community Engagement and Outreach Core will be expanding the practice-based research networks, which are collaborations with practicing physicians and clinicians throughout the state of Rhode Island in formulating and answering clinical and organizational questions relevant to their practices in the communities that they serve. Currently, Advance CTR has engaged with 104 clinics in our practice-based research network, with 7 active or onboarding studies, and we want to grow this. Community engagement studios were launched this past year. They will be increased as well. And they've been extremely popular, both with great reviews, both from community members as well as from investigators. And then, of course, we're working with the Swearer Center to enhance training on best practices in community-engaged research. The Health Research Corps, I'm happy to say, will be offering new awards, longer awards, and more funding, and also enhancing more networking in research. This will allow us to award funds using the Practice-Based Research Network, and also will allow us to support multi-site collaborative research awards with an emphasis on networking with other CTRs in other states, and also with hopefully with CTSAs in both IDEA and non-IDEA states going forward. There is, however, a continued need for partnership. We've been very successful in the past 10 years developing infrastructure, but we have work to do still. We need to formalize data governance policies among our institutions. We need to improve procedures for extracting and managing electronic health record data. And we need to build infrastructure to support REDCap and other databases so critical for modern research across Brown as well as across the state. I am so pleased and excited today. I thank you so much for everything that all of you have contributed to Advance Rhode Island CTR. We're particularly grateful to our institutional partners who've been generous with faculty time, with financial commitment, and with most importantly, with moral support in all of these endeavors. So at this point, I'd like to introduce Dr. Methodius Tuuli, who is a professor and chair of obstetrics and gynecology at Brown, and MPI on the recently submitted renewal of our grant for phase 3. So, Method, take it away.
Thank you so much, Sharon, for your leadership for Advance RI-CTR and for your personal friendship and mentorship. So, good evening, everyone. It's my pleasure to be joining the leadership of Advance CTR so that together we can move this really impactful project to the next level as we look forward to renewal funding. But my job today is to introduce our keynote speaker, Dr. William Powderly, who is truly a leader who exemplifies clinical and translational research as we celebrate our own work here today. Dr. Powderly holds many leadership roles. He is a professor of medicine at Washington University in St. Louis, director of the Institute of Public Health, the Institute for Public Health, and importantly, he serves as Associate Dean for Clinical and Translational Research as he leads the Institute for Clinical and Translational Research called ICTS at WashU. I will tell you that Dr. Powderly's contributions through Advance CTR has really built one of the most dynamic translational ecosystems in the country. I was lucky to cross paths with him when I trained and was a faculty member at WashU. And in many ways, WashU, what they have achieved at WashU, in my mind, is the frame of reference of how academic, clinical, and community partners can work together to move discovery and health improvements forward. Under his leadership, ICTS at WashU has accelerated advances from bench to bedside, launched many training programs for emerging scientists, and strengthened community engagement. Together, WashU has nearly $1 billion in NIH funding annually, ranking second in NIH funding in the country. Dr. Tuuli himself is an infectious disease specialist, and his work spans more than 3 decades, ranging from advancing treatment for long-term care of people with HIV to guiding national responses to emerging infectious diseases such as COVID-19. His work has not only influenced clinical practice, but also how institutions organize themselves to respond to epidemics and pandemics. He has a broad worldview, ranging from the US, of course, but also across the pond in the UK. What makes his work most impactful is that he doesn't think about research only ending in a publication, but really the publication being the beginning of then translating those discoveries to individual outcomes and ultimately to a population level impact. So please join me to welcome Dr. Tuuli, our keynote speaker.
Thank you, Matthew, for that kind introduction. Thank you, Dr. Rounds, for the invitation. And it is my great pleasure listening to you, Dr. Rounds. I'm extraordinarily impressed at the amount of work that has happened over the last 10 years and bringing it, and I know from personal experience, bringing something like this into fruition and then really guiding through the next generation of physician scientists, clinician scientists, and people involved in translational science is a truly remarkable endeavor, and I congratulate you for all of the work that has been done. You'll see echoes of what Dr. Rounds has been talking about. During my talk, I will talk about some of the opportunities and challenges, but I will also say that, we are undoubtedly in an uncertain time. I want to start with this figure because I think it's quite startling. The last year we have data on the United States spent almost $50 billion on biomedical research. 48 million of that was through the NIH. In this period of time, in fact, over the last 40 years, as you can see from this graphic, the investment in healthcare, never mind healthcare research, investment in healthcare in the United States has grown more than any other country in the world. Yet our health outcomes have actually fallen behind most of the advanced world. We've been from being in the middle of the pack in 1980 to being at the bottom of the pack in OECD economies in wealthy countries. Now, this is not just a relation to our health system. It relates to many challenges we have in public health and in our population in general and the way we organize ourselves. That said, it does raise the question that you increasingly hear when you talk to members of the public who are informed about this and to people in Congress who are informed about this is, what are we getting for our money? And it is critical for the reasons you heard earlier, for the future of biomedical research, for the future of our economy as a country, that we think through that question and are prepared to answer it in a thoughtful way that will allow us to continue to do what we have been doing, but do it better and in a more refined way. As much as 20 years ago, almost 20 years ago now, the Institute of Medicine looked at this question and really said that one of the challenges that we have is that we are not good at translating basic biomedical science into population level outcomes, whether that's at an individual patient level or at a community level or people as a whole. And it called for an increased emphasis and increased investment in translational research. That call led to the organization of the CTSAs and ultimately the organization of the CTRs. The challenge I think we have is that although we have now got an organizational framework, we are not moving the needle fast enough. We are not accelerating this pace of movement from discovery into patient-level research. And is that better? Apologies. And we are not moving it as rapidly as we ought to. So the CTSAs were established, and in part were established to do this. And you've seen the map of the CTRs. This is the map of the CTSAs. Very bi-coastal, but there are a few in the middle of the country, not least of which is ours. And we are designed to do exactly what you are heard about, to try and accelerate from basic science through multiple mechanisms into population level research. It's really important when you start this process, and it's good to have a dean here, as to why should institutions, whether they're hospitals, healthcare environments, or medical schools and universities, invest in this. And it really is, I think, gets to a couple of really core issues. The first is that we need infrastructure to support our researchers. It's redundant and inefficient to keep reinventing the wheel. So you need that infrastructure to provide the coordination and support, particularly for larger grants. That supports existing research. And we have estimated, in terms of our return of investment, figures very similar to yours. But we've also been able to show that in some way, and it may be indirect and it may be a little bit stretching it, almost 20% of the research generated at Washington University has been influenced in part by what we do in the Institute for Clinical and Translational Sciences. And that's going to become even more important if, as has been suggested, the NIH moves away from the current model of discovery science and will have a requirement of early human work even in basic science. And so it will be critically important that you have an infrastructure at an institution that allows you to do that. The other thing that I think becomes more and more important is we need better infrastructure. And by that I just don't mean just bricks and mortar, but actually the people who will do high quality clinical research, particularly clinical trials. And Dr. Rounds touched on that. And as a clinical trialist, I will say that is absolutely critically important. Now, you know, this is the spectrum. We don't refer to it as much anymore, but I think it's actually incredibly useful. This the notion of T0 being discovery science, T1 being the first in man, T2 the clinical trials that show evidence, and then the implementation into the clinical arena and implementation or translation into the public health arena. I will say to you, somebody whose initial training was in a basic research lab, but whose career has been at the clinical interface and clinical research, that it is critical to continue investment in basic science research, in T0 research. As someone whose career spans 2 pandemics, we would not have had the answers and the rapidity of the responses to those 2 pandemics without investment in our basic virology and immunology understanding that allowed us to accelerate that at a time of great need. And so it is critical that we think about discovery science and advocate for the continuation of funding for discovery science. But it isn't good enough to say we should do it for the sake of science itself, because that is not going to get us the investment in the political arena in the current environment. It can't be a bridge to nowhere. It has to be a bridge to improvement in human health. And we have to be able to say that, and say that in a meaningful way, and not just, as many of us have done over the last 40 years, when we see a basic research grant and someone says, fund this and I'll have a cure for Alzheimer's. Well, that's not going to cut it. And so it's critically important that we think about this. And what that leads to is something that I hopefully will have an opportunity to get back to, is starting to think at a biomedical science level of how do we do the early work to allow us to accelerate into the clinical arena and into what sort of experiments will actually help bring us there faster. So our mission is obviously the same as yours. We're disease agnostic, and that's really important because what we're trying to do is enhance clinical translational collaboration, build upon the research capacity, and provide training and careers for young investigators. I want to say, though, and I really want to emphasize, that we cannot assume that this has been a success. It is a journey. I believe we have been successful, but we're not successful enough. We have more to do. Why should investigators come to us? Well, I think you heard most of the reasons already. Access to these core services, whether they're technology that is not readily available otherwise, advice, consultations that's relevant to their science, access to training, access to funding, and help with grants in the process of grants. And we have many processes very similar to the ones you've outlined. Again, bring us back to the institution level. As a dean, one of the things you want to do is attract the best and retain the best. And therefore, it's critically important that you not only attract from outside, but you build from inside. And building from inside requires an infrastructure, particularly in clinical science, that is very different from traditional science. WashU has one of the largest and oldest MST, medical science training programs in the country. It's very, very successful, but it trains people for bench science. And it is critically important that in parallel, we also train people for clinical investigation. And then we also, and we create an environment where they can start to come together at an earlier stage in their careers and learn from one another. We talk about this as translational medicine, and I often say that the real role that I have is that basic scientists speak one language, clinical scientists speak another language, and the translation is actually true translation. It is getting somebody who can actually speak both languages. It gets even more complicated when you bring data science into it. I was asked to talk a little bit about career development for younger faculty who may be in the audience, and particularly about my own career. And I thought in the context of this I would not make many remarks, but I want to make a couple. That it's critically important, I think, to start this journey early with young investigators and ask them what they want to do. Where do they want to be and why? Too often people follow a pathway because that is the traditional pathway, as opposed to what are you trying to accomplish? What is you want to do? And then can we help you on that journey? And that becomes that by changing that framework, by changing that question into how do I fit into a structure, as opposed to how can the structure help me, it actually also makes those of us who develop these structures start to think about, are we actually doing the right thing for the people that we are training for the next generation? And I think that's a critically important, because one of the things that you get to leadership in part over time, but there are generational changes. And you've got to reflect and think about those generational changes as you think about who the next generation of physician scientists will be and how their careers will be best suited. And our structures need to match that. I tell this anecdote when I give talks on career development all the time. Bob Petersdorf was the foundation dean at the University of California, San Diego. He was an infectious disease expert, and UCSD's medical school was started in the 1970s. And in 1978, when I was a final year medical student interested in infectious diseases, he wrote an editorial in the New England Journal of Medicine about what the country needed in terms of futures doctors. And this is a direct quote from his editorial. As you can imagine, for an aspiring, academically oriented infectious disease, wannabe infectious disease internist, this was a little daunting. So my advice to every young career investigator is follow what you want to do, not what the expert tells you. Because 2 years later were the first reports of what then became AIDS. And I think it goes without saying that infectious diseases has been transformed as a scientific discipline, as a medical discipline by that pandemic, which trained a new generation of clinical investigators and a new generation of biomedical scientists. And it actually was pivotal for a couple of reasons. One was the training of clinical scientists, but you may not know that HIV/AIDS was the first disease in which the community demanded and got a role in what direction should research take. It was enormously controversial. but it was actually Tony Fauci, then director of NIAID, who invited the community into the planning of clinical research for HIV. And that led to many other groups, and now what has become part of the norm. We've had a second pandemic. I think all of you have challenging memories of that period of time. What I want to use this pandemic as an example of what we did well and what we did not do well, I think, as both as a country and in terms of the CTSA. So we had, in contrast to any previous national emergency, we had an existing infrastructure for clinical and translational research. We had 61 CTSAs and I think 12 or 13 CTRs. So you say to yourself, well, there's a way we could actually respond well as a country. We have this infrastructure. We put a lot of money into it. How well did we do? At an individual institutional level, we did quite well. Most CTSAs were actually vital in catalyzing their institutional responses to COVID. Many of them established biobanks, centralized decision-making, expedited things like IRB review, data management and data policies, went to remote interactions with patients. So there was innovation in remote trials, novel informatics, and so forth. And in fact, there were a series of papers in the Journal of Clinical and Translational Science talking about how well the CTSAs did. I gave a talk at a CTSA meeting about a year and a half later and said that if I was grading them as a university professor, I would grade the CTSA response as C-. We thought we were very good. But we weren't as good as we thought. Now, I think at an institutional level we were very good. And to give you an example, we responded quickly at the behest of our dean. We put together a decision-making group that rapidly made decisions as to what research we should continue, what research should stop, or we redeployed staff. We accelerated our processes from a regulatory perspective. It was a lot of work that people put in over a short period of time, and it was not sustainable. But it was an incredible response. And it led to some really outstanding outcomes. We had a biobank approved by IRB with the data management structure and the linking of phenotype with that biobank in place before the first patient was ever seen in St. Louis. Because we saw it was happening. I came back from a meeting in February and said, this is happening, and went to the dean and said, we need to do something. And within 4 weeks, we had everything ready to go before the first patient hit the door of our emergency room. So the reality is it can be done, but it was a huge amount of work. And to ask people to keep on doing something like that is not a sustainable enterprise. There were some interesting lessons from COVID. This is data from Janet Woodcock and colleagues, and looking at all the trials that were in clinicaltrials.gov in 2020 for COVID therapeutics. And this is a good example of what we did really, really badly. Every institution had investigators that said, I have a great idea. There was no national, well, there was a national response, but it took forever to get going. And everybody wanted to do something. Everybody wanted to get together. But we didn't have a framework in which we could get together and decide what to do. So there were literally hundreds of small, underpowered studies that would never give an answer. And I would argue that not only is that a waste of money, it is fundamentally unethical. To enroll a patient in a study that you know will not give an answer is not ethical. In contrast, in the United Kingdom, where they actually have an organized health system for an entire country, they managed to do 2 major groundbreaking clinical trials in a period of 6 weeks. Get them analyzed, get the results out 2 weeks later, and publications in the New England Journal of Medicine in another month. The NIH response was slow and tedious. And there were real problems. If you think about this from a national perspective, many sites had no prioritization mechanism. And if they did, they didn't automatically give priority to large national studies that would give an answer because they were still invested in having their own institutional roles. There were many industry funded studies, and again, no prioritization as to what would give you the best answer and most quickly. Many people improved their regulatory framework, but as someone who led one of these national trials, many sites didn't change how they negotiated contracts. And without naming certain universities, there were some that took 9 months to finalize a contract with the NIH. And there were 2 that we dropped altogether because they were incapable of doing it, including one in a city not too far north of you. There is a process of having a single IRB, but pretty much every institution also wanted their own IRB review as well. And there were challenges from a clinical perspective that I'm not going to go into. But it is a clear message to us. What were the best practices for an academic health center? And I think, it's always good to be able to say to a dean what you should do. Clear articulation and alignment, so clear communication with everybody. Obviously leadership, prioritization and transparency of the decision-making process. And putting in the right sort of mentoring and administration to an ability to be adaptable. So what do we need as a country? We need increased engagement, we need increased expertise, we need to embrace the technology, but bridge these technical divides and expand the efficiency of clinical trials. So all of these are things that CTSAs and CTRs can do. But what we do need to actually, if we're going to do that, we do need to actually do them deliberatively, and we do need them, this to become a priority for the NIH. I have a number of different slides. I'm going to rapidly run through them. I want, because I've been signaled that my time is up, but I want to say one other thing. We talk about the gap between discovery and clinical introduction to clinical into humans. There's an equally large gap between having that discovery, showing it works, and then actually changing your healthcare system to actually adopt it. And that gap really requires a different mindset, a mindset that really talks about implementation science. And I won't go into it in great detail, but I will say that if we're serious as academic health leaders, we have to say that it's both. We need to do both. We need to discover and we need to implement. And the interesting thing, again, and we also need to do it in collaboration with our community. And this is another area where I think CTSAs and CTRs has really taken the lead. But I wanted to I showed this to our dean actually quite recently, because we worry about the NIH, and I worry about the NIH and the current environment. But if you ask the question, has there been any place where there has been a significant, real major change in how the NIH is starting to think about moving the needle? It's actually an implementation science. So this is the rise of funding for implementation science from the NIH. In 2015, if you read the strategic plans for the institutes, only one, NIMH, NIMH had the word implementation in their strategic plan. Now, all of them have. And the reason is quite simple. You've got to be able to show this, that the investment is actually going to translate into better health. The final thing, we refer to the translational science benefit model. That was actually developed at Washington University by Doug Luke and colleagues. And it's really important because it's saying this question. In academics, we traditionally measure impact by counting things, papers and grants. That's irrelevant to the public. It is totally irrelevant to the public. And so we need to change that. And they have now 32 domains, and we're training our investigators and training so that they can communicate this in terms of what is the benefit of translational science. And it has been adopted now as the impact model by 70% of the CTSAs, and by more and more them moving towards it, because it really does change. But it's really important that you train your investigators to use it, and then you train, or not train, you get your institution to recognize it. Because if I can't promote somebody on the basis of their impact, then we're going to be an extinct breed. So we have to defend the academic health system because we believe in it. We believe it in its promise. But if we're going to do that, we have to really think why we're doing it and how we do it at every level. So the CTSAs and the CTRs are a national resource. COVID showed that we can respond and deliver high quality translational research in an unanticipated public health emergency. However, right now we have a potential to be a national network, but we are not incentivized to do so, and we're not coordinated in any way. So the big question is, can we step up? Can we make that case to the funders? Can we make that case to the NIH? And then once having made the case, can we deliver it? So thank you, and I apologize for going over a few minutes.
Questions?
I'll start things off. Thank you so much. That was great. With regard to can we step up to the task, it's very interesting. The CTRs are struggling with this right now. We're expected to become a networked CTR, but how do we do that? With whom do we network? And I actually believe that this requires some kind of positive incentives and infrastructure to make it happen. But I also think it's very, and I'd like your opinion on this, it's also, isn't it really critical that the individual faculty investigators have their own ties, their intellectual and scientific ties with colleagues and other institutions? And how does one incentivize them to build these networks on the basis of the scientific question and the collaborative opportunity?
No, I think that's a great question. It's quite ironic. We had our annual CTSA national meeting 2 weeks ago without the NIH. So it was actually a little bit of fun because you could actually say things that you... and that very question came up. I've been around long enough to realize that both individuals and institutions respond well to incentives. And so what we have, CTSAs, CTRs are disease agnostic. They're disease agnostic in part because what we're trying to do is promote common excellence in how clinical research is done. But it's equally critically important that we recognize that someone who is doing neurodevelopment research in pediatrics is not going to be the same as somebody who's doing obesity research in internal medicine. It's not somebody who's focused very much on issues related to avoiding premature death and infant mortality. And so the question really becomes, can you do both? Can you have a national infrastructure that is capable of responding in emergencies and to major issues, and at the same time allowing people to work well together? For all of my great concerns about the way things have been done, there are reasonable questions to ask about whether the siloing of the institutes at the NIH is fit for purpose for what we need in the next 20 years. And I could make this very strong argument as a biomedical scientist and a clinician scientist that it's not. And I think one of the things that we have to do as a scientific community is actually start to articulate with people who care about this and who are not just out in La La Land, that we want to be partners in doing this better. All of us want to improve the health of all our communities. And the way we're doing it right now, I don't think any of us could say it's working. So if it's not working, we need to start I think, coming up with alternatives, and then working with those of people in the community outside of the academia and research and the healthcare environment to create that that support. Somebody mentioned at the beginning about you mentioned about in 2016 the NIH got its NIH increase. The driver of that was Roy Blunt. He was a Republican senator from Missouri, and I got to know him. And he was very conservative. I would say I disagreed with him on 90% of what he stood for. But he was passionate about the NIH for three reasons. One, he believed that its ultimate promise of better health for everybody was critically important. Secondly, he believed that it was an economic engine for the United States. And thirdly, he believed that it gave us an edge in attracting the best of the world to come to the United States. We have got, I hope, to get back to that sort of approach and leadership in this country. If we can, then we can be partners. Long answer. Apologize for that.
Questions?
Yeah, that was a wonderful talk. So my question has to do with that second gap that you identified, changing the healthcare system to accept novel treatments, whatever you're developing. That's a real pain, isn't it? Because you get to a certain point, and if an insurance company shuts it down, that's sort of above your pay grade as a scientist. You can't really move forward. What can you do?
Well, again, I think it's part of it is changing the dialogue and changing the frame of reference. What can we do? So we talk about implementation science. We were one of the country's leaders in implementation science. We were the first CTSA to actually introduce it as a core program back over 12 years ago. And but you put the word science in there, and it intimidates so many people that I've gotten to stop using implementation science, and I've talked about it as change management. Yeah, change management. And we're teaching people. And so in the background, you can have the implementation strategy, an implementation science strategy, because that's important for people who want to write grants about that. But not everybody wants to write a grant. What they want to do is change what they're doing. And we can have the discussions with the C-suite of the hospital about if we want to improve quality and give the best care to patients, we have to start thinking about how to do that in a way that you will agree with. You may have to make an initial investment in, but the payoff will ultimately be our benefit. The greatest challenge in the United States, as you well know in this room, is the fragmentation of our payers. In contrast to countries that have a different system, where what happens 20 years from now matters because they'll still be paying for it. Because our insurance companies have no real stake in whether or not somebody gets something you can prevent something in the long term. It becomes a challenge. But again, I think that is slowly but surely changing. One of the things that we did in order to move our implementation science is when he retired, I actually brought the retired chief medical officer for the hospital into the implementation science team to do the reverse, teach clinicians what sells at the C-suite. In other words, how you frame this now, you asked a question about beyond that, but I think if we can start with our health systems and get the people who have to lead those, it's part of this engagement, then I think we can, again, start to make that difference.
We can take one more question. No one?
I think Sharon had the question that I wanted, so thanks very much for that, Dr. Powderly. That was a great talk and really enjoyed it. You just answered a question about implementation, so I'll take you back to the earlier part and the earlier part of your talk when you mentioned how at the basic science level, the importance of integrating human research into it. And so I would be curious at that early phase how you and leaders at WashU are thinking about that.
So we're also writing our re-competition. So it's due next year. Goodness knows what the heck we're going to be facing. But one of the things that we're going to offer to our basic science community is what I will say is an early implementation consult. Many of you in this room who do clinical research will have been asked at some point in your life to advise pharmaceutical companies, biotech companies. They already have their discovery, and now they're trying to figure out, how will it change things? If I develop this drug, if I introduce this new diagnostic, will people buy it? It's a concept similar to that. Most of us have domain expertise. We have world-renowned experts in various diseases, and our basic sciences rarely talk to them. And so this was triggered about, just a quick anecdote, this was triggered about 2.5 years ago when somebody came to me and said that they had a new technology or a new target that they believed would, if properly developed, would lead to a cure for AIDS. And you go through what they thought it would need, and from their early work and their cellular work, and it's probably going to need a continuous infusion. And I sort of looked at them and said, we now have a pill people can take every 6 months. No one is going to turn around now, and either patients or doctors, and give something that you have to give by continuous infusion. So let's rethink what you want to do. That you might have a druggable target, you might, but you're going to have to rethink about how this means something. And it occurred to me that this person had never talked to a clinician. They had never talked to a clinician as to what the true problem is for the disease that I am, looking after. And so we're going to start this process, and there are a number of reasons, not just for the CTR, CTSA reason, but also our dean is very interested in accelerating commercialization. And if you have a good idea and nobody wants to buy it, then it isn't going anywhere. So we'll see.
So now it's my very great pleasure to end our program with an award. So we thought it would be kind of fun to celebrate our 10-year anniversary by offering an award to an investigator who has been engaged with Advance Rhode Island CTR and who has demonstrated the both excellence in research as well as career progression over the course of time. And this award includes a very nice plaque, but also $10,000 to support the research program of the recipient. And 10 years, $10,000, it all makes sense. So we had really a remarkable group of nominations for this award. It was actually a really tough decision. I tried to cobble together enough money to have more than one award, actually. But be that as it may, our panel, consisting of representatives of all of our partner institutions, had a tough job. But we were able to make a decision, and I'm very pleased to share with you today that we've selected Dr. Chathuraka Jayasuriya, Associate Professor of Orthopedics at the Warren Alpert Medical School and at Rhode Island Hospital, as the recipient of the first decadal Advance Rhode Island CTR Clinical and Translational Research Award. Now, just a word about his accomplishments. Chat works in the area of regenerative medicine. He has been working to develop a novel cell-based therapy using cartilage-derived human stem cells to enhance meniscus healing. This work has been done in collaboration with clinician colleagues in the Department of Orthopedics, and it's been a very productive and worthwhile team effort. The work has promised to significantly reduce the incidence of chronic osteoarthritis, which can be a sequelae of joint injuries common amongst young people, athletes, military personnel, etc. His chat received a pilot project award from Advance Rhode Island CTR that kind of got this work off the ground. He's subsequently been successful in obtaining research grants from the NIH, the Department of Defense, and the National Orthopedics Research and Education Foundation. So, Chad, please come forward to receive this award. We're going to take a picture. Let's see. I'm afraid we got it. So here you go.
Yes, absolutely, yes. So I want to thank the Advanced CTR and Dr. Rounds and Ed for really supporting the launch of our lab. We received this grant in 2017, and that was when I was really starting my lab. And I have to say that without that grant, we wouldn't have been able to get the subsequent funding. We were recently able to launch a company for this technology, and now we're at the stage we're looking for VC support. So things are moving really quickly, and we can't be more excited about this. I just also want to say that the Advanced CTR is so important for Rhode Island's ecosystem of innovation and entrepreneurship, because it's a direct pipeline that feeds young investigators and introduces them into certain groups of people that will help them develop new technologies. So thank you again, and I look forward to the next 5 years. 10 years, 10 years, yes, of course. Thank you.
So that concludes our program. We're a little over time. Sorry about that, folks, but that's good. It was fun. And we have a lovely reception waiting for us outside, so please join us. Take a look at the posters, and thank you all again for all your contributions to our program.